Real life, sir.
Yes. Yeah. Shall we share?
Yeah,
Yes,
yeah.
sir. Dr. Ketan will.
Dr. Sridevi,
Yes, sir.
you can start.
Good evening, everyone. Welcome, Satyanarayan sir. It's my pleasure to introduce Dr. M. Satyanarayan. Mr. Vivek, can you please open the CV slide?
Yeah, it is shared. It is shared.
Dr. M. Satyanarayan is a HIV specialist and director of Ashwini HIV Care and ID Clinics, Kukutpalli, Hyderabad. He is a senior consultant family physician, retroviral specialist, and diabetic care physician. He is running one of the oldest healthcare delivery clinics in Kukutpalli area of Hyderabad for the last 38 years. He specialized in the field of HIV/AIDS medicine and providing dependable health care to the people living with HIV/AIDS in urban as well as remote rural areas. He is trained in HIV/AIDS medicine from NACO, New Delhi, USA, from University of South Florida, Tampa, and Grant Medical Foundation, Harvard Medical School, Boston, and John Hopkins, Baltimore. Participated in several knowledge exchange and update programs in HIV/AIDS at Glasgow, UK, San Francisco, Washington, DC, Kuala Lumpur, Johannesburg, and Melbourne. He is a member of International AIDS Society, life member of AIDS Society of India, member of TREAT, that is Therapeutic Research Education AIDS Training Asia.
Okay, so thank you, sir, for accepting the invite as a speaker. So the World AIDS Day is approaching on 1st of December. So before that, we at MQR thought that to uh, take few sessions on HIV to raise the awareness for the patients as well as training the respective physicians for HIV. So thank you very much, sir, and over to you, sir.
Good evening, everybody. Thank you for the introduction, Dr. Sridevi, madam. I convey my advance wishes to all of you on the occasion of World AIDS Day 2025 tomorrow. At the outset, I thank MQR for giving me this opportunity to discuss on this topic, what is new in ART and future ART options, and what are the present day challenges in HIV cure. Before going into details, let us remember a few words about the history of HIV infection. HIV was discovered about 4.5 decades ago. We made some progress in the management of the disease. We didn't understand it fully even now. Cure and vaccine development is still a dream. Even today, HIV remains the most challenging viral infections on the planet of Earth. 3 decades back, before the advent of heart, it was a death sentence. Now it is a chronic manageable disease like diabetes and hypertension. So in the coming 45 minutes or so, I will discuss on few topics. Let us talk little about HIV/AIDS in the beginning, about the heart, and the equation U and U. And later on, what is new in antiretroviral therapy? And next, the present future options of ART. What are the ARTs in pipeline in 2025? And finally, we'll discuss about the cure aspects, cure challenges, and what are the research trials going on in attaining a cure in HIV. All of you know what is HIV, what it does, and how it is transmitted. A few words about this. HIV, you know, HIV stands for human immunodeficiency virus. It targets the immune system, especially the CD4 cells, which are very important for cell-mediated immunity. It causes a progressive immune damage, leading to the increased risk of opportunistic infections, and of course cancers and target organ damage, which leads to death, majorly transmitted via blood and semen and vaginal fluids, of course through breast milk. Once HIV infection is established in the host, it is a permanent, irreversible lifetime infection like hepatitis B, hepatitis C, and herpes simplex virus, so on and so forth, like cytomegalovirus, Epstein-Barr virus, varicella zoster virus, etc. HIV infection is still considered as one of the major global health problems at present times. All of you know this. AIDS. What is AIDS? AIDS stands for acquired immunodeficiency syndrome. All of you know. The chronic HIV infection progresses to AIDS if it is untreated. It is defined by very low CD4 counts, that is less than 200, or it is called as advanced HIV disease, along with opportunistic infections, AIDS-defining illnesses, and cancers, etc. Without treatment, it leads to severe OS, malignancies, and shortened survival. So, you know, since discovery in the early 1980s, AIDS has become one of the most serious global health challenges, but our highly active antiretroviral treatment has transformed it from a fatal disease into a chronic manageable disease. AIDS is not just a medical condition. Literally, it is a story of science, how it has developed in phases. And it is a struggle of the patients and the strength of the patients also to tide over the difficulties of the disease, from the fear and stigma to hope and treatment. The fight against the AIDS shows how a global collaboration, AIDS by UNAIDS and WHO, and the compassion that can save millions of lives. It is estimated that about more than 4 crore AIDS-related deaths were prevented in the last 30 years due to heart. So coming to heart. Heart is highly active antiretroviral treatment. It's a cocktail of 3 or 4 antiretroviral drugs used to treat the HIV infection. It helps to restore the immune function, prevents the disease progression, and allows the people living with HIV to live longer and with quality of life also. HIV suppresses the ongoing viral replication and halts the progression of the disease and brings down the viremia into undetectable levels. Here we have to know about something about the undetectable levels. Practically, in the undetectable state, no transmission risk to others will happen. It's called U is equal to U. Now it is popularly called as U means undetectable. Undetectable is untransmittable. Similarly, another saying has come that U is equal to me. Recently, a short film is also produced by some of our professional colleagues. That is, U is HIV infected on ART with below detectable viral loads. Me is HIV uninfected. So both are equal. Now with heart, HIV infection is considered as a chronic manageable diseases like, hypertension and diabetes. So this is U is equal to U. Few words about the U is equal to U. This is a concept introduced in 2016 by a Prevention Access Campaign Society. It is an important global transformative public health message given by them in the fight against HIV. This is not just a slogan. It is scientifically proven fact, supported by multiple global studies and endorsed by WHO, UNAIDS, and of course CDC. It highlights the power of antiretroviral therapy in both saving the lives and preventing the new HIV infections and promoting the public awareness. It eliminates the fear, fight against the stigma and discrimination persisted for decades together, and it also supports the global HIV 95-95-95 goals. It is not only a medical milestone in the field of HIV, but is also a message of dignity and hope. This cartoon is from World Health Organization. I took it from the policy book. Is it going on, Vivek? Hello?
Yes, sir. Yes, sir.
Is it going on?
Yes, sir. It is live, sir. It's going.
Yeah. This cartoon is from WHO policy book. Here, this cartoon says undetectable means that is target not detected, below detectable levels. So it is if it is less than 20 or 40 or 100, depending upon the high-end PCR mission diagnostic equipment used. Here, green light shows undetectable, not detected. At orange light, undetectable means no measurable virus, zero risk of transmission to sexual partners, a minimal risk of mother to child transmission. This is theoretical, but in practically there is no risk of transmission to anybody. Orange shows the suppressed or detected suppressed viral loads. That is, viral load is detected, but it is less than 1000 copies per ml. And unsuppressed means more than 1000 copies. So unsuppressed means the patient might be missing the doses, or he is not under the strict follow-up. So the ultimate goal for all the people living with HIV is to maintain sustained undetectable viral loads. So taking antiretroviral therapy as prescribed will support this goal. And in this way, we can prevent the transmission to the sexual partners, and we can prevent mother-to-child transmission also. So in our medical profession, even somebody gets a needle prick or a sharp instrument injury from a HIV positive patient who is on RTV, who is on retroviral drugs and with undetectable viral loads, as per the occupational post-exposure guidelines from British HIV Association, PEP is not recommended for them. This is a short, all of you must be knowing that is a short film of about 20 minutes duration produced by our professional friends from Pune. Theme is breaking the stigma, emphasizing that people living with HIV are just like anyone else. Because when HIV is undetectable, it is untransmittable. Anybody can watch this movie in YouTube. It is available for free. Now, coming to the second part of our topic, today's talk, what is new in ART, that is two-drug regimes. Now, the two-drug ART has shifted from an experimental stage to mainstream scenario due to strong randomized clinical trials and real-world data. Current guidelines endorse the options like dolutegravir and lamivudine, of course, for first line and for switch, and dolutegravir and rilpivirine for switch only, and cabotegravir and rilpivirine long-acting for switch. And of course, very few trials are there on boosted protease inhibitor with lamivudine in special cases. Success of two-drug regimen depends upon the patient selection, and patient should have should not have a pre-existing resistance. Before switching on to two drug, we have to be very careful in seeing whether patient is already resistant to some other drugs. And they should have HBV negative status. That is also an important factor because of the tenofovir issue. Stable virological, they should have in stable virological suppression at least for a minimum of 3 to 6 months before switching. And of course, 100% adherence is needed. We have to go to the adherence history and see that patient is adherent in the past. And there should not be any drug-drug reactions. These are the criteria for taking a patient into two-drug regime. Modern two-drug regimes are equally effective or equally good as triple-drug regimes in properly selected chronic HIV patients. With the viral suppression rates consistently matching to, they are matching to three-drug regimes in major trials like Gemini, Tango, and SWORD trials. Evidence is strong, covering over 4,000 participants within 3 to 4 years of follow-up. It confirmed a long-term durability and safety. The key advantages of two-drug regimen includes a lower drug exposure, reduced toxicity, and fewer pills and lower costs, and the availability of long-acting injectable options to support adherence. Now, the global guidelines, present global guidelines, increasingly recommend the two drugs for both initial and switch therapies, reflecting its reliability and clinical acceptance. Let us see the major two-drug regimen major trials. Dolutegravir and lamivudine shows robust results in both treatment naive, that is Gemini trial, and switch therapies, that is in Tango and Salsa trial populations. Long-term follow-up up to 48 to 144 weeks showed a stable virological suppression and virtually no emergent resistance in any of the trials. And another true drug is dolutegravir and relpivirine. It is a SWORD trial. This is switch trial only. In this trial also, viral suppression is maintained in stable patients even at 148 weeks with excellent tolerability and low failure rates. So third study is with a long-acting cabotegravir and relpivirine. This is an Atlas and Flare switch trials. These trials show a long-acting option with equivalent efficacy and a strong patient satisfaction because of the duration of injections in 2 monthly intervals. All the patients at the end of the trial, at the end of 152 weeks, the patient satisfaction point is a very, very considerable and important point in these cases. So third one is protease, retinoid boosted protease inhibitor with lamivudine. So that is GARDEL and ENDIS and SALT trials. So these trials combinations, these two, protease inhibitor and 3TC combinations are effective. It is a less ideal choice due to its metabolic effects and of course pill burden. We have to take 2 pills. So now coming to the long-acting injectable ARVs. So with this, the major benefit is eliminating the daily medication. So daily pills are not necessary. So it will reduce the pill fatigue, which helps the individual who struggle with pill burden. Privacy concerns also will be very less with long-acting injectables. So once there is no question of daily taking tablets, their stigma is reduced. So long-acting injectables can improve the adherence and maintain a stable drug levels with fewer drug interactions compared to some oral regimens. Most of patients report high satisfaction levels due to convenience. So the long-acting injectables, first long-acting injectable is cabotegravir and rilpivirine, is the first complete injectable ARV regimen designed to replace daily pills in people who are already suppressed. It uses 2 IM injections administered monthly or once in every 2 months, once in every 8 weeks. It is approved for maintenance therapy, not in treatment-naive patients. And oral lead therapy is now optional because some clinicians preferring and some clinicians are not preferring, and patient preference also varying in the oral lead therapy. This slide, long-acting injectable ARVs, this slide highlights all the long-acting injectable HIV treatment and preventive options other than cabotegravir and rilpivirine. Lenacapavir. Lenacapavir is currently the most advanced, offering twice-yearly dosing for multi-drug resistant HIV and being studied in broader populations, including for PrEP. Slatavir. It is initially very promising drug, some 1 year, 1.5 year back trials, as a monthly or implantable long-acting agent, and it is undergoing some reformulations to address earlier safety concerns. So coming to the broadly neutralizing antibodies, they represent a novel biological approach, maintaining suppression in small studies, but currently limited by some reports of resistance are reported, and of course due to some cost concerns. Research is ongoing into ultra long acting drugs and implants and nanoparticles to achieve dosing intervals of several months, even to years. So now let us go into and discuss the ARVs in pipeline in 2025. First, we will discuss oral tablets that are on pipeline. So now lenacapavir and bictegravir, it's being studied in Artistry 1 and 2 trials as a new once daily. One is a capsid inhibitor, another is an integrase inhibitor. The combination of capsid inhibitor and integrase inhibitor in oral therapy, daily oral tablet. So Artistry 1 trial at week 48, similar results of virological suppression are observed with the current regimens, slightly more discontinuations. The reason is unknown for us. So a pharmacokinetic data supports dose at the phase 3 with a single tablet regimen. That is a little bit a concern. PK data is coming in the way. So another combination of daily oral tablet is doravirine and slatavir. Slatavir is 0.25 milligrams. It is being studied as a once daily combination in first line and switch studies versus bictegravir, TAF and FTC. Coming to the once a week oral tablets, there are about 6 agents are in developmental stage for once a week oral dosing. Slatavir, lenacapavir, etc., all these GS 1720, GS 4182 and GS 5894. All these combinations are already in phase 3 studies, likely the next wave of approvals. The key concern, as we discussed in the earlier slide, is the pharmacokinetic durability by the day 14, at the end of second week. If a weekly dose is missed, the drug levels are not maintained and the resistance concerns are coming. Slatavir and lenacapavir combinations is also a once a week studied as 2 milligrams of slatavir and 300 milligrams of lenacapavir. In phase 2 studies, they are in phase 2 switch results. The similar viral suppressions are similar with other compared with bictegravir and emtricitabine and TAF at the end of 48 weeks. PK data supports weekly dosing but no data at day 14 is available yet to confirm the PK studies. The second phase, 3-switch trials are also underway. That is called Island 1 and Island 2 studies. So these are all from MSD and Gilead mostly. So this thing is another drug is slatavir plus unoravirin. So this is a NNRTI similar to doravir. This is from MSD. It is in phase 2B studies and dose finding study is ongoing for this once a weekly dual regime. So lastly, these studies, the molecules like GS 1720 and GS 4182, they are from Gilead. And a weekly integrase inhibitor, that is GS 1720 plus a capsid inhibitor in combination, that is GS 4182. There are 2 phase 2 trials are in treatment naive participants and also in switch study versus bictegravir and emtricitabine and TAF. This GS 1720 integrase inhibitor with it is having a 9-day half-life. So these are the various studies, various trials going on once a week oral tablets. Coming to once in 2 monthly injections. This is from ViiV company capsid inhibitors, that is VH499. It is in phase 2A studies tested as a 10-day monotherapy in ART naive individuals. It is intended for self-administration. Unlike other injectables, this is 2 monthly injectable ART, which is paired with an integrase inhibitor. So second one is cabotegravir, that is once in 2 monthly injection. Cabotegravir long-acting plus lenacapavir. This is a off-label study going on. This is investigator-led study. This drug is used once in every 4 to 8 weeks, cabotegravir long-acting plus 6 monthly lenacapavir in individualized regimes. So this is also submitted in CROI 2024. This study is presented in CROI 2024 by Dr. Monica Gandhi. This is once in 3 monthly injections. These are also on pipeline. This is molecule is GS 14 plus GS 6212. This is from Gilead. And another one is a prodrug of slatavir, that is GS 1614 and GX 6212. It is a new integrase inhibitor. Both are evaluated now they are in phase 1B study in people living with HIV. Results are not yet released, but still this trial is in very early development. So this is once in 4 monthly injections. So this is ultra long acting cabotegravir and rilpivirine. So this cabotegravir ultra long acting shows a much flatter pharmacokinetic profile. It is a subcutaneous form, nearly 6 months longer half-life than current 2 monthly IM cabotegravir. This is an intramuscular injection form, nearly 2 months longer half-life than the present day one. It supports the potential long duration, more than 4 monthly dosing. So finally, once in 6 months injections. These are from ViiV company, VH184, third generation integrase. This is a third generation integrase inhibitor with distinct resistance profile. So another one is VH310. This is a cabotegravir prodrug with a slower pharmacokinetic profile. It releases 6 monthly dosing, and first in human studies planned in 2025 by ViiV. So like this, there are various long-acting, broadly acting broadly neutralizing antibodies are being studied. They are in various phases of research. So finally, once in 12 monthly injections, that is once in a year injection. This is also in pipeline. That is lenacapavir. This is only for PrEP, for not regular patients. This is only for PrEP. It is a capsid inhibitor, you know. It is in phase 3 trial for PrEP. Study started in 2025. It is also from Gilead, being developed as a once yearly injectable option for PrEP only, HIV prevention only. So now we have seen all the research which is going on in pipeline. So now we'll come to the last topic, cure. So what are the present challenges now? Cure, why it is becoming difficult in dealing with HIV patient management are, as all of you know, HIV doesn't eradicate. As a latent viral, it stays in our body as a latent viral reservoirs. It will persist in the body despite the highly effective antiretroviral therapy. So for that, usually lifelong treatment is usually required with 100% adherence. So if incomplete immune recovery results, if antiretroviral treatment started late. So now that's why test and treat policy has come into the picture. So long-term complications on central nervous system, kidney, heart, and metabolic disturbances and malignancies and early aging are worrisome with long-term HIV infection. Of course, stigma and adherence issues, access to ART supply chains, lab facilities, and funds and research remains the major hurdles. Now the slogan for World Health Day is the funds. Funds are lacking of late. So with the insufficient funds, the progression of disease prevention, cure, and all the research studies are at halt. Coming to cure, there are of course two cures, as you know, for HIV infection basically. One is a sterilized cure, otherwise called as a classic cure or eradication of virus from the body, means a complete elimination of all replication competent HIV virus from the body, including the latent reservoirs in the tissues at the sanctuary sites like lymph nodes, brain, and GI tract. In essence, the virus is gone and cannot rebound. That is called eradication or classic cure. This is extremely difficult because HIV integrates into the host DNA and establishes latent reservoirs at the time of infection itself. At the time of entry of HIV into our body, latent reservoirs are formed. So they are in the resting CD4 cells in tissues, which are very hard to detect and very hard to even measure by available measuring techniques like viral load measurements, and even harder to eliminate. However, because you can never sample even a single infected cell in the body, providing absolutely that there is no replication competent virus is essentially impossible, very difficult to have a complete cure, that is eradication. Given all this, the sterilizing cure remains a holy grail, but it is very far from widespread clinical application. It is not possible at present. The other one is a functional cure or a treatment-free remission. In this type, the virus is not eradicated, but it is permanently controlled without ongoing medication. The person maintains an undetectable viral load and no disease progression even after stopping the antiretroviral therapy. It is essentially a treatment-free remission, as in we see in cancer patients, that can last for years, months, sometimes mostly years. Same thing will happen with present-day hepatitis C treatment. Hepatitis C treatment, with the advent of the anti-Hep C drugs in 2004, sofosbuvir. So they achieved a treatment remission for, that is that is a wonder in the hepatitis C management. As of now, in HIV, neither a sterilized or functional cure is available. All of you must be knowing a Berlin patient, Timothy Ray Brown, the first person who cured of HIV. So he is a known case of HIV since 1995. He was diagnosed at that time with acute myeloid leukemia in 2006. He received a hematopoietic stem cell transplant therapy from a donor with a rare genetic mutation called CCR5 delta 32 in 2007. And it is considered to have achieved something very close to a sterilizing cure. He survived for more than 12 years without HIV medications. He died 12 years after bone marrow transplant due to recurrence of acute myeloid leukemia. Like this, only 5-6 we can count on fingertips. Only 5-6 people worldwide achieved a cure via this method. So before understanding the concept of cure, we should have some idea about the HIV structure and replication cycle. All of you know that HIV is a double-stranded RNA virus. The outer layer is a lipid envelope studded with glycoproteins like GP120 and GP41, which help the virus to attach and fuse with the CD4 cell chemokine receptor sites. Two single-stranded RNA in the virus is the virus genetic material. HIV attaches to the CD4 cells through chemokine receptor sites like CCR5 and CXCR4 and enters into the CD4 cells where it converts its RNA into DNA and integrates into host genome irreversibly using the reverse transcriptase and integrase enzymes. Once integrated into the host cell DNA, it is permanent. The virus intelligently uses the host cell machinery to produce new viral particles, which are released and they infect the other CD4 cells. Like this process keeps on going. So a latent virus is a form of virus that remain in a dormant inside the infected CD4 cells, and HIV can settle and hide in infected CD4 cells in dormant state at some known sites they are called sanctuary sites. Those are all lymph nodes, bone marrow, brain, testis, and a gut microflora, that is GIT. And in some unknown compartments in the early phase of infection itself, at the time of infection, some CD4 goes and settle as a latent cells. The latent virus don't express viral protein spikes, GP120 and all, on its surface. Those are antigens. Hence, they will not come under the immunological surveillance. So once they escape from the immunological surveillance, our immunity won't do those latent virus. And another thing, latent virus can't be identified through laboratory tests because they don't express the viral proteins. So antiviral drugs, all our drugs are ineffective on latent virus as they do not replicate because these our drugs will act while the virus is actively replicating. Because of the replication, they block the enzymes with different enzyme blocking agents, then we can stop the replication. Once those won't replicate, the drugs won't work. Latent reservoirs are long-lived and continuously they keep on replenished from below detectable viral load states of the host. Even below detectable, right, some viruses are actively circulating in the body. Those viruses will go and substitute last latent virus. The latent virus replication, this latent virus is also replication competent and discontinuation of the AR titers. So the latent virus reservoirs are the major obstacle to achieve eradication or to get a sterilized or a classical cure. So, but as we discussed earlier, like Timothy Brown, a handful of people maybe 5-6 patients, including Benign and Randall patients, attend a sterilized cure with bone marrow transplant or stem cell transplants. These projects, these surgeries, everybody can't practicable. They are not scalable. These procedures are risky. But a handful of people became HIV free after a special bone marrow or stem cell transplant for leukemias. So they are not applicable or scalable. Okay, this indicates a cure is. They indicate a cure is possible. There is a solution, but it is not the way. All the attempts done by using shock and kill were unsuccessful. Hence, the intense efforts are directed towards the functional cure only at present. So these are the ongoing research trials for HIV classical cure. Let us see the ongoing trials. On classical cure first. The Timothy Brown case, that is allogenic CCR5 delta through stem cell transplant. These have achieved a complete viral eradication in a handful of cancer patients like Timothy Brown and Dendon patient. It works by replacing the entire immune system with HIV-resistant donor cells. It is effective but too risky and only applicable in patients already needing stem cell transplant. It is, of course, not practicable. And second is a autologous gene editing, autologous gene edited stem cell therapy. Here, the patient's own stem cells are modified, usually knocking out the patient's CCR5 and reinfused. Early trials, they showed successful engraftment of the HIV-resistant cell, but not complete reservoir clearance has happened. So this is a failure attempt. The third one is in vivo CRISPR excision, that is called gene editing tile excision, such as EBT is a tool, gene editing tool therapy. It is designed to cut off the integrated HIV DNA sequences with a molecular scissors. Early phase 1, phase 2 data, they show a good safety and some delay in the viral rebound, but no durable remission occurred so far. So this trial is also not effective and it is also not up to the mark. Overall, each approach offers an important proof of concept, a milestone, but all remains experimental with safety, scalability, and reservoir elimination are the key challenges in moving forward. These are all the obstacles which come in the way of cure. So this is also another trials like classical cure trials like shock and kill plus immune clearance, CRISPR immune clearance. Here is the idea to wake up so you stimulate the latent HIV cells and then destroy the infected cells using the immune-based or a gene therapy, gene editing tests like as we discussed the CRISPR tools. Early data shows these trials were conducted by National Institute of Health and University of California and San Francisco and Temple University. They initially look promising, and this approach is now moving towards the first human safety studies. We have to wait and see what are the results, future results of these studies. Another trial is a classical cure trial is a CAR-T and TCR-T gene therapy trials. These trials adopt a cancer-style gene therapy. Now, in cancer therapies, gene therapy is playing a lot of role. These T cells are engineered to specifically recognize and attack the HIV-infected cells. These phase 1 studies from Pennsylvania and University of California and South Florida show a good safety and work is going on to achieve a deeper reservoir clearance. These results are also, we have to wait and see. So HIV resistant, third one is HIV resistant induced stem cells. Here, scientists are doing a gene editing to stem cells to make HIV resistant immune cells. Then we have to differentiate them from the functional T cells. So Harvard Medical School and Massachusetts General Hospital in Boston has shown a proof of concept in vitro with a future potential as a scalable alternative to stem cell transplant. So now coming to the functional cure. So because classical cure is not become that practicable, let us concentrate on functional cure. These approaches aim from ART-free remission not a sterilizing. So these broadly acting neutralizing antibodies. So the passive immunotherapy, some patients maintain suppression for 6 to 12 months of discontinuation of antiretroviral treatment in Rockefeller and Oxford and National Institute of Health trials in US. So this broadly acting neutralizing antibodies plus lenacapavir and these are all dual long-acting regimens show a durable suppression, and it has also a FDA approval. So another way is a therapeutic vaccine. So ELIX-003 trial, not 3 trial in Spain, they boost the T cell immunity. So early it is treated, individuals showed that a prolonged ART-free remission that was also recorded. So last one is the TLR9 agonist and broadly neutralizing antibodies. These combination trials show immune stimulation with antibodies. They delays the viral rebound after treatment interruption. This is also a significant study. Keep on results. We have to wait and see. The TLR9 is a receptor that is found in the dendritic and T cells, dendritic cells and T cells and some macrophages. So this is the take-home message finally. So in brief, ART has evolved from lifelong daily pills to simpler, safer two-drug regimens that are effective versus three-drug therapy in selected patients. Long-acting treatments like cabotegravir, rilpivirine injections, twice-yearly lenacapavir are transforming the care of HIV patients, and they are improving the adherence, reducing the stigma, and moving us towards the pill-free HIV control. The ARTs in pipeline in 2025, they are strong, they are weekly or monthly oral agents or ultra-long-acting injectables. Their implants are there, and combinations with the broadly neutralizing antibodies aiming for dosing every 3 to 12 months. Finally, the cure remains still challenging due to persistent latent reservoirs, but rapid progression is happening in the cure concepts also. It is active now on multiple fronts. Classical cure with stem cell therapy based on gene editing and other strategies. A functional cure with broadly neutralizing antibodies and therapeutic vaccines and immune stimulation and long-acting ARVs. Overall, HIV is now, it is a chronic manageable disease. Antiretroviral therapy is becoming longer acting and simpler, and cure science is moving from theoretical to real clinical feasibility. Hope for the future. Let us hope. Scientific breakthroughs and community engagement and support and global collaboration should pave the path towards the HIV-free world. Thank you for patient hearing, sir. Thank you very much, all of you. So let us continue improving the lives of people living with HIV. So thank you for your patient hearing.
Yeah, thank you very much, sir, for your enlightening presentation. And we have a lot of audience which have joined. Some have joined from Malaysia and so on. So they are viewing your webinar. So there is a question. One question I could see from the audience. So this is from Dr. Subramaniam. He's asking, what is the first line of treatment for newly confirmed HIV patient?
Now the present guidelines are telling that integrated strand transfer inhibitors in INSTI based regimens with tenofovir and with a NRTI backbone.
Right, sir.
All the guidelines are suggestive, either dolutegravir or bictegravir with tenofovir alfanamide or emtricitabine. Tenofovir diproximal fumarate or lamivudine.
Right, sir. So few doctors are saying, sir, it is a very elaborate discussion you have given for HIV. So So you have given very nicely. You have put in there is a once in 3 months therapy and once in 2 months therapy for HIV
Yes.
in your presentation.
They are
So,
all pipeline. They are in pipeline. Yes.
sir, we just ask your views on this because you have dedicated your 35 years for HIV. So, what is your views on the current or the future of HIV treatment?
It will become very simpler because of our you people. Pharma industry is a real boon for our India. You people like other you companies come with all the long acting, even injectables, all the drugs. You should come with a generic market. I hope you soon come into the market with flying colors by introducing to the all patient populations with a long-acting injectables, then the scenario will be changed completely. Let us hope this will happen soon.
Right, sir. Right, sir. Now, this is another question from Dr. Kapil Sarde. How to explain the how to explain the corollary use of injections in HIV treatment, considering risk of transmissions by HIV through infected needles?
So I think all these injectables, they are equally equipotent. Once upon a time, HIV-2, NNRTIs are not effective on HIV-2. But I hope all these new generation, all the drugs like integrin strand transfer inhibitors and capsid inhibitors, they are all effective against even HIV-2, as far as my knowledge goes.
Right, sir. Another question, sir. Now questions are coming up. This is Dr. Rituparna Saha. What is the most common type of drug resistance in HIV?
These are all, the resistant barriers are improved with the present day drugs. So previous drugs like lamivudine and previous NNRTAs are all, they had a very low resistance barrier. Present day resistance is not a big concern if the minimal more than 95% adherence is if they adhere to good adherence, more than 95% adherence, in my clinical practice, I have seen rarely a resistance with the dolutegravir. For the last 5-6 years, integrin strand transfer inhibitor resistance I have not seen.
Okay. So let me check if there are more questions. Okay, there are another question from Dr. Anand P. Can we start two-drug regimen in patients with, or can we start two-drug regimen in a virologically suppressed patient? I'll just put
Yes.
on the chat
No,
box.
there are in treatment Navy patients also trials are there to start a true drug regimen. But we are nowadays our practice now is switch therapy now. But research shows that two drug regimen can be like dolutegravir and lamivudine. I mean, can be treated started in treatment Navy patients also. Data shows that it is equipotent. I mean, viral suppression even at the week 48, there is no difference when compared to the triple drug regimen.
Yes, sir. There is another question that when to do testing after, or when to do HIV testing our PEP completion.
Usually, it is 6 to 8 present day fourth generation ELISA tests are very potent, very accurate. Even at the week 6, they are very effective for a serological test. So all these markers, serological markers, using the recent generation antigen antibody dual tests, you can do it at the end of 6 weeks or at least by end of the 8th week.
Right, sir. Thank you, sir. Now, this is another question. Is two-drug regimen in practice now?
Pardon me, sir.
Is two-drug regimen in practice now? Means is
Yes.
it used? Yes, it is used.
Yeah. So two drug regimens so it has come in the guidelines also, right? In some guidelines, I heard that it is there. So practically we are using it in well suppressed patients, and we see the history. But HBV should be negative, and there should not be any resistance, prior resistance, and adherence profile should be good. So they should have more than 95% adherence rates. So we check at least 3 to 6 months. So adherence below detectable levels are there. We can switch over to two drug regimen.
Right, sir. Right, sir. Yeah, I think questions have stopped now. So, yes, sir. Finally, I would like to ask you, so what message you will like to give to the treating physicians for the treatment of HIV?
So thorough initial evaluation. So seeing all the, because at the time of detection, diagnosis, so complete evaluation of the patient is not being done in majority, especially in the government sectors, because of the affordability issues. But a complete thorough investigations with all like hepatitis B, all other comorbid states like VDRL. Nowadays, VDRL is also very, very common. So HSV, these infections they go hand in hand. So we have to screen and we have to evaluate and we have to see, because viral suppression is not a big problem. Problem is other metabolic problems like, seeing regularly urine kidney function with EGFR and proteinuria and protein creatinine ratios. These parameters are very critical before starting treatment. Because of cost concerns, majority of people will not do, but it will really worth doing it, keeping aside the cost. So then we have to understand the patient in depth, and some patients are going into malignancies like lymphomas. So especially for those who are having less than 200 CD4 counts, we have to see for cervical smears and all the other antigens like cryptococcal antigen and toxoplasma, CMV, and all the screening should be done. Another thing is vaccines. So we should encourage all the immunocompromised, especially these special cases. So we should insist to take all the vaccines. So this will reduce lot of morbidity like pneumococcal, influenza, Tdap. So this will boost the immune system, especially the adult vaccination program is in the limelight nowadays after 50. For all these immune compromised patients like HIV patient, the age is not the barrier. Irrespective of age, all the HIV patients should be vaccinated.
Right, sir. Thank you, sir. There is a question which is coming from Dr. Sagda. Just let me check. Will the use of injections for HIV treatment increase the risk of transmission to healthcare workers or other caregivers?
Like giving injection needle prick.
So I think he's asking about lenacapavir. So lenacapavir is already available in the form of sterile. These are basically they are given. These vials are basically sterile. These are preservative free. There are no visible particles. They have been sealed properly. So the pack of lenacapavir internationally, they're providing two disposable needles which are sterile. So this is a new treatment now. So I don't think it will increase.
No way, sir. No way. Even a patient who is on below detectable levels, so with the present day treatment, so even a needle prick injury, even a sharp injury will not transmit HIV. These are all, theoretical possibilities. If you see the CDC data after 2001 or 2, there is not even a single case reported with needle prick injury HIV transmission. So it is very, very, very unlikely, even with treatment, a needle prick or occupational exposure, through occupational exposure, HIV will be transmitted. These are all old versions. Maybe possible at that time because of this, and the viral load, the viral inoculum which is being transmitted through a needle prick injury is very, very low. The theoretical possibilities are there. Nowadays, CDC also says that oral sex will not transmit HIV. I have seen a poster in the CDC because of the low possibilities, because of the emerging data. So the transmission concepts have been changed. British, I have shown a slide. British HIV Association has declared that a patient on ART with undetectable, even with a needle prick injury, you need not take PEP.
Right, sir. So we'll take one or two now final questions. So the question from Dr. Rituparna Shah. He's asking, what is the status of HIV vaccine development?
This is also just like cure, because the cure vaccine concept is also, natural HIV infection is not cured. So vaccine trials will get succeed. We will follow the protocol of the natural infection. So where the natural infection comes and heals, then only vaccine development will come. A infection like HIV, it is very difficult to formulate a vaccine. That's why vaccine trials are repeatedly. There are several reasons. One is that, and because of the genetic instability, and there are no proper model. Animal model is not available to develop a vaccine, and technology. We don't know, sir. At present, cure and vaccine trials are at very difficult, because a lot of trials have gone done, and majority of trials have come to a certain level and they are not successful. But still going on, we don't know. So there are promising trials now for vaccines also.
Thank you, sir. Thank you so much. And finally, Dr. Anand is asking that is this a possibility of lenacapavir made available in India? So I'll answer. So MCure is working out with for this, and maybe in 1 or 2 years, maybe lenacapavir may be launched in India.
Yeah. So we are all eagerly waiting for that, sir.
Yes, sir. Yes, sir. We are working towards it. Yeah. Okay.
Thank you, everybody. I thank all the participants for taking their time and coming and present here over this 1 hour session. Thanks, everybody. I wish we will continue these programs in future also, for the enlightenment of our knowledge, and participant knowledge.
Yes, sir. Thank you very much.
I thank once again to MCure for giving me this opportunity. Thank you very much.
Thank you, sir. Thank you, sir, for your illuminating presentation today. And I hope the audience has benefited from it. And you have brought in a lot of, sir, clinical pearls for the audience. And from MQ's side, wishing you a good evening ahead. And to the audience, thank you very much for logging. And we will definitely keep these webinars to educate the audience as well as enlighten them on HIV. Thank you very much, sir.
Thank you.
Sir. Thank you, sir. Okay.
Thank you. Thank you, sir.
Thank you. Thank you. Okay. Okay. Thank you all. Thank you. Thank you, Dr. Sridevi. Bye.
Thank you. Thank you, Dr. Sridevi. Nandakishore, we can stop. We can end the session.
Okay, thank you, sir.
Yeah.
Thank
Thank you.
you.